Very good evening, everyone. My name is Dr. Abhishek Thakur, and I'm representing Emcure Pharmaceuticals here. Emcure is a pioneer in the field of gynecology and IVF. Programming 28 is a scientific theme this year for all the webinars, and this is based of managing an ovarian cycle with different gonadotropins, GnRH analogs, hormones as per different protocols. We will always be a preferred partner in terms of the scientific and academic initiatives, and all the platforms where our support is required, we'll be more than happy to do so. Today, on this special occasion, we have two eminent speakers who are going to talk about the RPL and evaluation and approach to the infertile couple. To introduce the speakers for the evening, I'll welcome and I would request Dr. Lloyd D'Souza, who is the honorary. Hello, I'm audible?
Yes, you are audible.
The honorary secretary of IMA Bardes, and he's also the consultant and occupational and consultant and family physician based out of Goa. Over to you, sir.
Good evening and welcome to the state level webinar being organized by IMA Bardes on infertility. The journey to parenthood can be full of challenges, and for some couples, these challenges can start right from the moment when they consider planning for a baby. A couple who's trying to get pregnant for a while now, but not getting the good news, may wonder what's wrong with them. One of the reasons for not being able to conceive could be infertility. But as physicians, we need to reassure them that there is no need to lose hope. There are various treatments available that could help one get pregnant and bring that bundle of joy in their lives. Today, we have two eminent speakers and very experienced speakers who are going to guide us on this topic of infertility. Dr. Amol Lunkar and Dr. Ramesh Gaikwad. They would be taking over shortly, but we shall just take a moment to be silent as we say the IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. The flag salutation. We, the members of the Indian Medical Council, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the comity of nations. Jai Hind, long live IMA. Well, dear colleagues, leadership is a capacity to translate vision into reality. And after seeing what we have achieved during COVID times, I would like to address every IMA member as a leader in his or own way. And to ensure that Team Goa outshines, we have our very own Dr. Rufino Montero leading IMA troop as the state president of IMA Goa. He is with us today, so I would request Dr. Rufino Montero, the state president of IMA, to kindly address the meeting. Over to you, Dr. Montero. Could you unmute Dr. Rufin, please?
Ankit, can you unmute, sir? Dr. Montero is there.
That's right.
Yes, correct. Sir, I think he logged out. He was there some time back.
Yes, he was there just now.
Okay. Yes, he's there.
Yes, I would like to call upon the president of IMA Bardes State, Dr. Rufino Montero, to kindly address us.
Sir, you need to unmute yourself.
Okay. Hello, can you hear me?
Yes, sir.
Yes.
Okay. Sorry for that inconvenience, but it is a great pleasure to be here today for this IMA Goa State CME organized by our enthusiastic branch IMA Bardes. As Dr. Lloyd said, we have to be harbingers of hope to couples who are struggling with infertility. And yes, we know that God is hope for everybody. And especially in our Indian tradition, second to God is the doctor. So it is very important.
I think he got disconnected again. Yeah, Dr. D'Souza, can you take over?
Yes, we shall move on. Before moving ahead, I would like to make a short announcement that this meeting is being digitally recorded and noted for your presence. So you do not need to post in your name or your registration number or any other details. When you log in, the login details and the timestamp and the duration stamp is automatically picked up by the software. So just get logged in and just enjoy this bonanza of information that is going to come up in a little while. I think we have Rufino, Dr. Rufino back again. Dr. Rufino, can you hear us? Yeah.
Unmute. Dr. Rufino, you will have to unmute yourself.
Hello?
Yes, we can hear.
As I was saying, in our Indian tradition, doctors are second to God, and we should be the harbingers of hope to the patients. We are the seen God by our patients. And in the faith reposed to us, we should carry on. And today's CME will definitely enlighten us how to go about this problem of infertility, which is quite a problem faced by many a couple. So, as I thank IMA Bardes team for organizing this very important seminar, I request all our members who have joined in to kindly be attentive, follow the guidelines, and have a fruitful discussion so that we can expand our knowledge. And that's exactly one of the main aims of IMA, which is the largest voluntary organization in this country, where our main aim is to foster the medical advances among the medical community, besides working for our society and doing various acts of social service. So with this, I thank IMA Bardes for the excellent work, and I hope that we will have many such seminars in the future to come. Thank you.
Thank you, Dr. Rufino. That was our IMA State President. I would like to call upon our IMA Bardes President, Dr. Vishwaraj Malshikar, now to kindly introduce our speakers for today. Dr. Vishwaraj, over to you.
Good evening, respected members. It takes me immense pleasure to introduce our first speaker for the evening, Dr. Amol Lunkad. Dr. Amol Lunkad has completed his MD in OBG from AIIMS. He has done his DNB and later FICOG and MNAS. He has done his fellow in ART from USA and also his diploma in bioethics and reproductive law at Harvard. He is a chief IVF specialist at Indira IVF Hospital and also a founder member of the Gynex Endocrine Society of India. He has been awarded the prestigious Indumati Javeri Award and also the Suli Rudra Sinha Prize for advanced gynec endoscopy surgery. He has authored several oral papers as well as chapters in various national and international research papers. He has done over 13,000 plus embryo transfers with around 9,300 plus successful IVF pregnancies. He is a winner of the Hall of Fame IVF Specialist of Western India at the All India Fertility Awards in 2019. He is also awarded as the most inspiring gynecologist of Western India 2018 by the Economic Times. With all his eminent awards and accolades, I would now call upon Dr. Amol Lunkad to please take over and enlighten us more about the same. Over to you, Doctor.
Yes, thank you, Dr. Vishwaraj, for your kind words. At the outset, let me thank Goa IMA and IMA Bangladesh for giving us this opportunity to interact with you all. I thank all the delegates for taking out time this Saturday evening and making this session interactive one. I will be speaking on resolving the mystery of RPL. So we know recurrent pregnancy loss is one such overall condition wherein it is not only distressing for the couple when a pregnancy loss occurs, but it also challenging situation for the doctors and the gynecologists so as to give a take-home baby to this couple. I bring you greetings from Pune and from Indira IVF Pune and my team at Indira IVF Pune. So let us look at this challenging situation, which is very well described by this, that when the world says give up, hope whispers try it one more time. Many times couples who come to us who have had several miscarriages, this saying goes very well with them. I will cover this topic under the following headings, or you can say the distribution of the topic would be, we'll look at into the definition of recurrent pregnancy loss, the overall prevalence, etiology, evaluation, and then the treatment. We know classically recurrent pregnancy loss is described as 3 or more consecutive pregnancy losses prior to 20 weeks of gestation. But for more practical purposes and with couples planning their pregnancies late and overall more and more pregnancies being highly precious, for investigating and treating such couples after 2 failed miscarriages itself. So the more or less you can say the modern definition is occurrence of 2 or more failed clinical pregnancies, or where 2 or more pregnancy losses occurs consecutively, we start evaluating and treating such couples. We can classify recurrent pregnancy loss into primary, secondary, and tertiary recurrent pregnancy losses depending on presence of previous viable infant or not, or as in tertiary recurrent pregnancy losses, there can be multiple losses interspersed with normal pregnancy. Overall, if you see, the incidence of recurrent pregnancy loss is around 1 to 2% of all couples. So around it is a big chunk when we say 1 to 2% of all couples will have recurrent pregnancy losses. So when a couple has a recurrent pregnancy, when a couple has a miscarriage or a pregnancy loss, what are the chances of subsequent pregnancy landing up into a pregnancy loss? That we'll see. The first pregnancy overall has a overall chance of 12 to 13% of landing into a miscarriage or an abortion or a pregnancy loss. After the first miscarriage, the chances remain almost same, somewhere around 14 to 20. But after second miscarriage, the subsequent pregnancy having a pregnancy loss increases to almost 24 to 29%. And that is why we start investigating and treating this couple after 2 miscarriages. After third miscarriage, the overall chance of subsequent pregnancy having a pregnancy loss is 31 to 33%. But if you look other way around, 3 consecutive pregnancy losses, the next pregnancy being live and healthy is almost as high as 65 to 70%. So the silver lining of the dark cloud is even after 3 consecutive pregnancy losses, the subsequent pregnancy being healthy is always a very high possibility of almost 70%. And the good thing is that after the 3 consecutive miscarriages, even if somebody has a 4th miscarriage or 5th miscarriage, the chances of subsequent miscarriages do not increase. They remain same as it was after the 3rd miscarriage. Now going to etiology of recurrent pregnancy loss. Of course, various etiologies are there, and other than the idiopathic, you can say recurrent pregnancy losses, the most common ones are the endocrinological, immunological, anatomical, genetic, and some infections and others like lifestyle, stress, and all those things. If you see the etiology or reasons of recurrent pregnancy loss and infertility, they go hand in hand to quite an extent. And many patients with recurrent pregnancy loss usually land up with secondary infertility, and even many patients with infertility have history of recurrent pregnancy losses. So it is very common for us or we IVF specialists to see patients of recurrent pregnancy loss in our day-to-day practice. Because if we see many reasons or etiological factors of RPL and infertility, they go hand in hand, or the same etiologies can cause infertility, or the same etiological factors can cause recurrent pregnancy loss. As the uterine factors, genetic factors, male factors, ovarian factor, tubal factor, cervical, immunological, and endocrinological factors, these can be common to both, may cause infertility or may cause recurrent pregnancy loss also. How we evaluate a couple with recurrent pregnancy loss? Of course, the history, whenever we start evaluation in any pathology or illness or any, you can say, ailment, then the first foremost thing to do is take a good history, then a routine general examination, followed by specific investigations, and then diagnosis and followed by treatment. So same is here. A good history is important, and the important histories are the menstrual history, history of contraceptive use, environmental hazard, history of any addictions in the couple. Because if the evaluation is proper, then only our diagnosis and treatment is going to be accurate. There would be certain general investigations which we do more or less in all couples who are wanting to go for pregnancy, which will include serologies of the couple, blood group, HB electrophoresis of the couple. Wife would undergo certain basic investigations like hemogram, sugar, thyroid, prolactin levels, rubella, immunity would be checked, because if she is non-immune, we would like to vaccinate her with the rubella vaccine, so on. Now coming to the specific investigations, we have to rule out various causes of recurrent pregnancy loss. And one of the common and easily treatable cause is the anatomical factor. It can be a congenital anatomical factor or an acquired one. The congenital causes of congenital anatomical factors which can lead to recurrent pregnancy loss is septate uterus or diadelphys uterus. So any uterine anomaly or any malformation of the uterus like bicornuate uterus, unicornuate, arcuate uterus can lead to pregnancy losses. Acquired recurrent pregnancy losses, the acquired anatomical factors can be Asherman syndrome, fibroid, endometrial polyp, or cervical incompetence. So good transvaginal 2D, 3D scan will tell us more or less many things about the pelvic anatomy, the endometrial cavity, the myometrium, the serosal surface, its relationship to each other, and the endometrial volume is all this, and the shape of the uterus and the endometrial cavity. So you can easily differentiate between a normal uterine cavity and arcuate cavity, a bicornuate, and a septate uterus. So your the figure D on the right lower side, it clearly shows that the serosa also starts dipping with the septation of the endometrial cavity into two. So it is more likely to be a bicornuate uterus, while the figure C, it shows that the serosa is intact and there is a single outer serosal surface, while the endometrial cavity is in two halves. So it appears to be a complete uterine septum. So it is very important to rule out all the anatomical factors in a couple with recurrent pregnancy. First and foremost investigation to be done to rule out a good, and the anatomical factor is a good transvaginal 2D 3D sonography. A simultaneously done 2D 3D scan will tell us almost everything about the anatomy, and anatomical defects can be ruled out. Presence of fibroid uterus, adenomyosis, or endometrial polyp, or intrauterine synechiae have to be ruled out. Not only these anatomical factors have to be ruled out, but if they are present, they are to be corrected to the best possible way. Like a septate uterus or a endometrial polyp or a endometrial fibroid has to be removed before we go for a next pregnancy. So correction of acquired anatomical abnormalities of the uterine cavity is recommended for patients with recurrent pregnancy losses. Do consider surgical correction of uterine septae or uterine cavity distorting fibroids or leiomyoma and adhesions or polyp. So these are the various recommendations. Again, you will see this video, which is a hysteroscopic video, and on hysteroscopy you will see that it is a complete uterine septum with the presence of vaginal septum. So we are entering into the one half of the cavity. This is a 2.9 French hysteroscope. Here you can see we have entered into one horn of the cavity. You could see the tubal ostia on the left side. We are coming back and we'll try to enter the other half of the cavity, and you will see the bridge in between the septa, which is separating the cavity into two halves. So such anatomical defects should not only be diagnosed but corrected to the best possible way, and then only the next pregnancy should be allowed. Then only our prognosis, the prognosis of the patient is going to be much better. Now you can see the septa in between. This was the vaginal septum. Now we are entering the right side of the cervix, and we will enter the right uterine cavity, the right horn. Here we have entered into the right horn, and this is the tubal ostia which is seen. Now simultaneously we go for correction. So hysteroscopic, we are doing septal resection using the Collins knife, normal saline as the distension media, bipolar cautery is being used, and using the Collins knife we have started cutting the septum, and we have perforated the septum to reach and started unification of the cavity. You can see here very well. It's a very simple procedure, daycare procedure, and a very rewarding procedure for these couples. Here you can see the septum being resected. As the septum being a vascular structure, we hardly require any coagulation, and as soon as we give a cut, it gets resorbed. So as we go towards, so always keep the ostia in vision. We should not perforate, otherwise it will be difficult. And keeping the ostia into vision, slowly we should basically resect the septum. As we go towards the towards the fundus, myometrial fibers, the pink fibers will start to appear, and that is the point where we have to be very careful. Always keep a little under correction. Do not overcorrect, because the chances of perforation would be more then, and also the chances of any weakness or perforation or dehiscence during pregnancy would be there then. So we have to be careful. Resect the septum. Simultaneously, some would also like to give in a cervical encerclage the same time, or you can give a cervical encerclage later during pregnancy also. Here we are resecting the lower part of the septum. So any anatomical abnormality should not only be diagnosed, checked for, but also corrected to the best possible way. Now here we are doing a laparoscopy, and we have diagnosed it as uterus diadelphys. So there are two separate uterine horns. Each horn is having its own fallopian tube and ovary, and you can see the sigmoid and the rectum going in between with the fold of the bladder in between. So here we can hardly do anything. We cannot correct this anatomical defect. Patient can go in for a next pregnancy with all precautions, and with preconceptional folic acid, and if required ecosprin, and patient can be allowed to conceive again. With tender loving care, she should have a good pregnancy. But such defects we cannot unify because it's two totally different horns with different adnexa, and the rectum and the sigmoid with the bladder flap in between. So various defects have to be not only diagnosed but corrected to the best possible way. Coming to the genetic factors, again, 2 to 5% of pregnancy loss would be due to genetic factors. So all patients with recurrent pregnancy loss, the karyotype of husband and wife is must. if we want to be more accurate, the karyotype has to be by microarray so that we won't pick up single gene defects or single gene deletions. Overall, balanced translocation, reciprocal translocation, Robertsonian translocation, inversions, these are commonly seen as genetic factors. And of course, we can also check the basically the genetic makeup of the product of conception. So whenever possible, the genetic makeup of the product of conception can be checked. But when the product of conception is not available or could not be checked, then the parental chromosomal karyotype should be checked for. And what is the advantage? Because if you know that it is a translocation or an inversion or a mosaic or a Robertsonian translocation, then we can do pre-implantation genetic diagnosis. We can take help of pre-genetic testing for structural rearrangement or pre-genetic testing for aneuploidy, and transfer only a genetically healthy embryo. So by doing IVF, we can generate embryos of people, check each embryo genetically, and the embryo which is genetically normal can be reposited back into the uterus to achieve pregnancy. Of course, it will add on to the cost of IVF and cost of genetic checking of each embryo, but then advantage would be fewer miscarriages, less emotional distress, and shortening of time to successful pregnancy. So genetic counseling of all patients of recurrent pregnancy loss is must, and genetic checking, that is the parental karyotype, should be offered. Chromosomal microarray would be preferred to karyotype, and pre-genetic testing, especially useful for balanced parental translocation, inversion, and single gene disorder. Pre-genetic testing for all patients of recurrent pregnancy loss is not indicated. Coming to the immunological factors. So after looking at specific investigation for anatomical factors, genetic factors, we are moving towards other etiological factors of recurrent pregnancy loss. Immunological factors, both alloimmune and autoimmune. Now the alloimmune is nothing but like a graft versus host reaction, so wherein the mother is basically rejecting the pregnancy. So failure of maternal immunological adaptation to the developing conceptors, resulting in a form of a transplantation rejection reaction and resulting in pregnancy loss. So how we can diagnose it is with the help of certain tests. The investigations are husband-wife lymphocyte cross-match, wife's TNF alpha levels, and wife's natural killer cell activity. Treatment can be active treatment or passive treatment. Active treatment with lymphocyte immunotherapy, wherein we take husband's lymphocyte in we wash those lymphocytes, and the concentration of the lymphocyte is it is basically allocated in 2 or 3 intradermal injections, and these intradermal injections are given to the wife for sensitization such that the alloimmune rejection decreases. What is passive treatment? We can use various immunomodulators like low molecular weight heparin, steroids, immunoglobulins, intralipids, or TNF alpha inhibitors to prevent this rejection. So basically the graft versus host you can say reaction is controlled and pregnancies are not rejected by the mother. Coming to thrombophilias. So most common, you can say, one of the preventive etiology of recurrent pregnancy loss is thrombophilia. Thrombophilias can again be acquired and hereditary. Acquired thrombophilias are far more common than hereditary thrombophilias. Acquired thrombophilia or APLA or Hughes syndrome can be again classified into primary antiphospholipid syndrome versus secondary antiphospholipid syndrome, depending on the presence of connective tissue disorders like SLE or Sjogren's along with antiphospholipid syndrome. So primary APS will have absence of connective tissue disorder, while secondary APS will have presence of connective tissue disorder. Now antiphospholipid antibody syndrome or the Hughes syndrome or the acquired thrombophilias can present in various ways, right from recurrent thrombosis to pregnancy morbidity to just recurrent pregnancy losses. It can present in various ways. It can be obstetric antiphospholipid antibody syndrome. It can be a catastrophic one with widespread thrombosis and thromboembolism, or the classical APS with recurrent thrombosis, or it can be a seronegative antiphospholipid antibody syndrome. Now, the diagnostic criteria used for labeling a couple or a patient with antiphospholipid antibody syndrome are the revised Sapporo's criteria. One clinical and one laboratory criteria has to be met to label the wife as having antiphospholipid antibody syndrome. So what are the clinical criteria? Is the presence of vascular thrombosis, at least one episode of arterial, venous, and small vessel thrombosis, pregnancy morbidity, that is one or more unexplained pregnancy loss of a morphologically normal fetus of more than 10 weeks, or one or more premature births of a morphologically normal neonate before 34 weeks due to severe preeclampsia or eclampsia, or presence of 3 or more unexplainable pregnancy losses less than 10 weeks. So any one of the 4 clinical criteria along with any one of the laboratory criteria, if it is met, then we can label the patient as having antiphospholipid antibody syndrome by the revised Sapporo's criteria. The laboratory criteria include anti-cardiolipin antibodies, IgG, IgM in medium to high titer, anti-beta-2 glycoprotein, again IgG, IgM in medium to high titer, and lupus anticoagulant. So these lab tests have to be done on 2 occasions, 12 weeks apart. Though many times practically it becomes difficult to do it twice, 12 weeks apart, but at least one clinical and one laboratory criteria has to be met to label antiphospholipid antibody syndrome. The mainstay of treatment remains with the use of aspirin, low dose aspirin, along with low molecular weight heparin or unfractionated heparin. Low molecular weight heparin, of course, is costly than unfractionated heparin. So more or less practically nowadays we use low molecular weight heparin along with low dose aspirin. The treatment will also depend upon presence of prior thrombosis or not, because if prior thrombosis is there, then the patient will require therapeutic anticoagulation, while if prior thrombosis is not there, we will give prophylactic anticoagulation. The dose of therapeutic anticoagulation for low molecular weight heparin is 1 milligram per kg twice a day, while prophylactic low molecular weight heparin as a prophylactic anticoagulation we use 40 milligram of low molecular weight heparin. So after acquired thrombophilia, the important other type of thrombophilia is the inherited or hereditary thrombophilia. It is quite rare for hereditary thrombophilia to cause recurrent pregnancy losses, but still in rare cases we have to evaluate, and if they are present, then we have to treat similar to as acquired thrombophilias. Now, the various inherited thrombophilias which can cause recurrent pregnancy loss are factor V Leiden mutation, prothrombin gene mutation, antithrombin 3 deficiency, protein C proteinase deficiency, and methyl tetrahydrofolate reductase deficiency. So we can look for hereditary thrombophilia also, and if they are present, we can treat with low dose aspirin along with prophylactic anticoagulation with low molecular weight heparin. Coming to the endocrinological causes of recurrent pregnancy loss, thyroid abnormalities, definitely they are associated with recurrent pregnancy loss, and even subclinical hypothyroidism is associated with recurrent pregnancy loss. So all patients with recurrent pregnancy losses, thyroid screening and screening for anti-TPO antibodies must, and any TSH above 2.5 should be, you can say, supplemented with thyroxine. Luteal phase defect, again various endocrinological abnormalities like anemia, PCOS, insulin resistance, hypogonadotropic hypogonadism, premature ovarian aging, premature ovarian, you can say fall in ovarian reserve, stress, exercise induced extreme weight loss, or higher ages. All these can cause luteal phase defect, wherein basically the corpus luteum function would be defective, and so the overall progesterone levels required for maintenance of the pregnancy would be less, and thus pregnancy losses would be more. So luteal phase defect has to be corrected by the you can say supplementation of progesterone, either oral progesterone or injectable or a combination of these, or vaginal progesterone, and various you can say studies have shown benefit of supplementation of progesterone in presence of luteal phase defect. Again, we have seen that PCOS causes hyperinsulinemia, increases insulin resistance, obesity, luteal phase defect is there, ovulation is defective, and thus overall the placentation and sustenance of pregnancy can also be defective, and thus PCOS can result in recurrent pregnancy losses. Diabetes, if it is missed, or there is a, you can say, glucose intolerance or an over diabetes, then again it can result into pregnancy losses. Most important thing which many times gynecologists miss is premature ovarian aging, diminished ovarian reserve, and a fall in AMH. So low AMH can also result into poor quality of oocyte, and this poor quality oocyte unable to sustain the pregnancy then, which is formed from the poor oocytes. So that can again, so AMH is an important investigation for patients with recurrent pregnancy losses. One more important thing which is quite commonly missed by gynecologists is the looking at the sperm for as a reason of recurrent pregnancy losses, because we usually towards the wife, but even the husband can be one of the reason for recurrent pregnancy losses. So high sperm DNA fragmentation index, so DFI should be done. If it is more than 15, then 15 to 25 is equivocal. We should start treating such couples, giving them antioxidant, vitamin E, vitamin C, coenzyme Q10. If it is more than 25, then it can definitely result into a recurrent pregnancy loss. And if it is more than 40, then ICSI with sperm sorting is the best way out. Hyperprolactinemia has to be corrected. Microbiological factors, the take-home message should be routine TORCH screening should be abandoned, and there is no role of TORCH infection to cause RPL, because even today, many physicians day in and day out for patients with RPL keep on doing TORCH titer. One should remember IgG levels, if they are high, that shows past infection. Only IgM titers, if they are high, that shows a present infection or active infection or infection in the recent past. So lifestyle factors, the only microbiological factors which can result into some pregnancy losses are bacterial vaginosis, chlamydia, which can result into endometritis and then pregnancy losses, or it can result into basically PPROM and preterm labor and pregnancy losses. Lifestyle factors are very important, because any cigarette smoking, alcohol consumption, obesity, caffeine, excess of caffeine, all these can result into pregnancy losses. So these have to be corrected, and that is why there is a role of lifestyle modification, diet, exercise, tender loving care in recurrent pregnancy loss. So de-stressing, reassuring, that is also very important. Psychological support is very important in patients with recurrent pregnancy loss. I will just finish with an interesting case, and then I will sum up this topic on RPL. This was a 32-year-old came to me in 2017. She had 8 pregnancy losses when she came to me. She had DNC done 5 times, and there were losses from March 2010 to almost February 2017, various losses. First 2 spontaneous abortion at 7 weeks. Then she consulted a doctor, karyotype was done, which was normal. Preconceptional folic acid was started, but still a missed abortion at 10 weeks. DNC was done. October 2012, again a spontaneous conception, and then a missed abortion at 12 weeks. 2014, she had an right ectopic pregnancy. Most probably 2 DNCs were done till that. Some salpingitis must have occurred, and a right ectopic pregnancy was there in her 5th pregnancy, which was medically managed with methotrexate, and then a repeat hysterosalpingogram showed that both the tubes were normal. In Jan 2015, again, she started with preconceptional folic acid, aspirin, low molecular weight heparin was also given, but a missed abortion at 11 to 12 weeks. To December 2015 pregnancy, everything went very well, but she had a PPROM and cervical incompetence and delivery at 22 weeks itself, while a cervical encerclage was also done. So there was a history of failed cervical encerclage which was done. So McDonald encerclage was done in her 7th pregnancy, which had failed, and in her 8th pregnancy, again a miscarriage at spontaneous abortion at 8 weeks. So she had 8 miscarriages when she came to us. We did her initial investigations, her baseline investigations, all were okay, except the hysteroscopy showed that the cervix was highly patulous. You can see the hysteroscopy image, and the panoramic view itself shows that the cervix looks quite patulous. Now, we also screened her for acquired and hereditary thrombophilia, and nothing significant was found. So what we thought is, because she has had various, you can say, etiological factors acting at various levels, so we needed to basically take all the factors into account and treat her such that no factor is left. So for her failed McDonald's encerclage, we basically took her for a laparoscopic abdominal encerclage. So laparoscopic abdominal, you can see the video here, because she had a history of several miscarriages with a failed McDonald encerclage. That is why a laparoscopic abdominal encerclage was planned. On putting in the scope, there were few adhesions, must have been due to previous some PID or salpingitis, or some momental adhesions were also there. After doing adhesiolysis and sharp dissection, then we opened up the UV fold. So here you can see the UV fold being opened up and sharp dissection being done. Once the UV fold was opened, the bladder was pushed away, and then at the level of the internal os, Marcelin tape was passed, and this Marcelin tape was tied anteriorly. This Marcelin tape will cause fibrosis and will strengthen the internal os permanently. So this is how a laparoscopic abdominal encerclage is done. So many patients of RPL with a failed vaginal encerclage, instead of doing an open abdominal encerclage, a laparoscopic abdominal encerclage is very good results, gives a very good strength. And so here you can see the Marcelin tape is passed and being tied anteriorly. The knot is then secured and the UV fold is then closed. Only thing is, we have to instruct the patient, now the next delivery will only be a LSCS. We cannot go for a vaginal delivery now. So here you can see the UV fold being closed. So after doing a laparoscopic abdominal encerclage, we gave her OC pills for 1 month, and then started her on preconceptional folic acid, low dose aspirin for 3 months. She conceived naturally 3 months after surgery. She was started on low molecular weight heparin with immunoglobulin. Her non-invasive prenatal testing was done at 12 weeks. High-risk pregnancy care was given, and she delivered a female baby at 36 weeks by elective LSCS, 2.55 kg female baby. So this is just coming to the conclusions or the take-home messages. So various causative factors have to be ruled out by doing various specific tests. Whatever causative factor is found to be positive, we have to treat that factor to the best possible way, and then only allow that couple to go in for the next pregnancy. Various factors and their tests are, you can see on the screen, and these all tests or factors have to be ruled out, and all those which are abnormal have to be taken care of, then only allowed to go for next pregnancy. What are the do's? We check for acquired thrombophilia. We should check for uterine malformation. We should check for genetic factors, endocrinological factors, modify lifestyle factors. What are the don'ts? Do not do other tests for thrombophilias. Do not consider low positive antiphospholipid levels as APLA. Do not do unnecessary DNCs. Do not check the luteal phase for progesterone levels. Do not do endometrial cultures, or do not do TORCH tests. So these are the don'ts to be followed. So these were the take-home messages. Thank you all for your patient listening. And back to the organizers. Any questions, if any, I would be most fortunate to answer. So thank you all for your patient listening.
Thank you, sir. Thank you, sir. Sir, we take the questions right now.
Yes, we can take 1 or 2 questions.
Yeah, so Dr. Diksha, are you going to read out the questions?
Yes. There are some questions, sir. There's a question by Dr. Sandeep Naik. He is asking if early menarche by itself is a contributing factor, as it means that by age of 35, ovarian exhaustion would have set in. And if menarche was at 9 years, do you agree with that, Dr. Lunkad?
It may not be true always, early menarche may be one of the predisposing factor for premature ovarian aging, but it does not always go hand in hand. So we cannot take early menarche as directly as a positive factor of RPL.
Okay.
It can be one of the contributing, you can say, factor for premature ovarian aging, but does not always stand true.
Okay, sir. Okay, sir. Any more questions? So if any more questions, we'll take it at the end of the
Yes.
Yeah. So Dr. D'Souza would be in. Dr. D'Souza, are you there?
I'll take over.
Okay. So I'll just display the CV.
Yeah. Hello, everyone, and welcome once again for today's session. I would like to introduce today's second speaker, Dr. Ramesh Gaikwad. Dr. Ramesh Gaikwad is a consultant at Indira IVF Center with over 10 years of experience in fertility management. He has several publications in international and national journals, and he has been a faculty for many national conferences. I would now like to welcome Dr. Ramesh Gaikwad. Over to you, sir.
Good evening, all. Am I audible?
Yes, sir.
Yes, sir. Audible.
Yes.
I would like to thank IMA Goa for giving me and Indira IVF this opportunity to come and discuss with you. Just continuation with Amol sir's lecture, I would like to discuss few points about how to approach and evaluate infertile couple. While going through this topic, I will cover definition, causes of infertility, evaluation of couple, and some specific investigations. So coming to definition, infertility is defined as inability to conceive after 1 year of regular unprotected sexual intercourse. If that couple is having regular unprotected sexual intercourse but still not getting conceived, then we will term it as an infertile couple. And in those cases, we need to start evaluating after 1 year of period. But this time period should be reduced to 6 months if female partner of them is more than 35 years, having genital or abdominal tuberculosis history, as well as having moderate to severe endometriosis or any other ovarian surgeries previously. So we will consider them 6 months in those couples, 6 months as an adequate time, and male partner having testicular surgeries done previously. So infertility is of two types. Primary and secondary infertility. Primary infertility, where there is no previous history of pregnancy occurred in those couple, and in secondary infertility, it is having history of prior pregnancy, although there is no live birth or irrespective of its outcome. Almost 10 to 15% of reproductive age group couple face this problem, and prevalence of infertility from age, it is almost same, but the demand for infertility care has increased, and that's why we do get so many cases in our day-to-day practice. And this demand for infertility is increased because of increased awareness, where people, they think that as like other illnesses, infertility is also one of the medical disease, and with medicines it will get cured. So they try to postpone, or because of some sociological changes like delayed marriages, delayed childbearing, reduced sexual frequency due to work stress and work pattern, or if those couple, because of work, they are not able to stay together. So these are the some changes occur over the period of time, has increased number of cases in our infertility OPD. This is the pictorial representation of our reproductive system, where you can see male genital organs here and female internal or genital organs here. Here, actually, hypothalamo-pituitary ovarian axis and hypothalamo-gonadal axis is the main hormonal cascade, which will take center stage here, and proper functioning of this HPO or HPG axis will be helpful in producing normal gametes in either male and female. And if normal gametes are produced, then only chances of getting pregnancy will be more. So causes of infertility we will discuss, and to simplify, in male partner we have divided these causes into three categories: pre-testicular, testicular, and post-testicular causes. Hypogonadotropic hypogonadism is one of the more important cause in pre-testicular reason. Here, this hypothalamic inability to produce this hypothalamus problem because of some accident or any neurological or accidental issues leads to decrease in GnRH secretion, further leading to decrease in pituitary stimulation and production of the follicle stimulating hormone, which is necessary for functioning of this HPG axis. Also, coital disorders like ejaculatory failure, which is mainly due to spinal cord injury, uncontrolled diabetes mellitus, chronic illnesses like multiple sclerosis, renal failure, as well as some chronic drug history. Erectile dysfunction is also one of the common cause, which is due to congenital vascular problems or due to psychological issues, as well as alcohol abuse and drugs history, and diabetes mellitus, which is uncontrolled. Loss of libido is seen in hyperprolactinemia cases, as well as retrograde ejaculation do come in our OPD, and it is mainly because of some damage to bladder neck due to previous surgeries like transurethral prostatectomy, retroperitoneal lymph node dissection, as well as also seen in uncontrolled diabetes mellitus cases. Coming to testicular causes of male infertility, these are mainly genetic causes, which is Klinefelter syndrome, Y chromosome microdeletions, immotile cilia syndrome, or Young syndrome. Then congenital causes is like cryptorchidism, which is undescended testes, and anorchia, which is absence of development of testes. Then infective causes, important causes, mumps, orchitis. In generally in pediatric patients, we do come across with these kind of infections. Then sexually transmitted diseases in adult. Then exposure to anti-spermatogenic agents like heat, irradiation, chemotherapy, or drugs which are causing damage to sperm production and their maturity. Then vascular causes like torsion, varicocele on both sides, which of grade 3 or grade 4. Then immunologic causes like anti-sperm antibodies in either semen sample or serum. Then idiopathic, which is actually one of the important cause of testicular dysfunction, and it generally occurs in fetal life, where this production of the seminiferous tubules or sperm producing cells get damaged or inadequate. Later on, further, it gives inadequate or inappropriate production of these sperms as well as their quality. Then post-testicular causes like obstructive at the level of epididymis or vas deferens level. It can be either congenital or infective reasons. In vas deferens, if it is congenital causes, congenital bilateral absence of vas deferens is one of the important term, where in almost 10% of the azoospermia cases, we do come across with absence of the vas deferens. Also, cystic fibrosis, which is again congenital disease in which these vas deferens get blocked in multiple points. Then acquired causes like vasectomy, inadvertent injury to vas deferens during any surgeries, as well as the infections in genital tract leads to acquired blockages in the vas deferens. Then male accessory gland infection, that is MAGI, mainly in the prostate as well as in seminal vesicle glands, it leads to damage to sperm quality and further infertility. Then immunological causes, same like idiopathic as well as post vasectomy and epididymal hostility, where this sperms get stored, and because of release of toxins or reactive oxygen species, they will get damaged and become inappropriate for fertility. Then coming to female partner causes, same like male factor, we have divided into 3 categories: pre-ovarian, ovarian, and post-ovarian. Again, in pre-ovarian causes, here hypothalamic pituitary disorders, mainly hypogonadotropic hypogonadism, which is actually one of the rarest condition, but we do come across in our routine practice. Then hormonal imbalances, which is actually most commonly we come across, that is polycystic ovarian syndrome, where there will be excessive production of the androgen as well as there will be oligo or anovulation. Then other hormonal disorders like Cushing syndrome, thyroid abnormalities, as well as micro or macroadenomas leading to hyperprolactinemias will also cause inability or inappropriate folliculogenesis. Then coming to ovarian causes, it is mainly anatomical causes and follicular cysts, ranging from follicular simple cyst to complex solid cyst. Also, sometimes we do come across with endometriotic cysts. In endometriosis, again, this ovaries either on both side ovaries get stuck to each other, as well as posteriorly to uterus. Also, there will be adhesions in pelvis, which will cause hindrance to oocyte pickup after ovulation. Also, there will be some ovulatory disorders occurring at the ovarian level. Then coming to post-ovarian causes, mainly damage to fallopian tubes, and infection is the leading cause here. Infection to fallopian tube causes damage to fallopian tube, as well as inappropriate motility of the tubal musculature, as well as if this infection gets spread to both ovaries, maybe these both fallopian tubes, both fallopian tubes get damaged, and further leading to formation of hydrosalpinx, pyosalpinx, as well as blockages of the tubes. Then coming to uterine causes, in uterus, fibroids, adenomyosis will also take part in causes of the infertility, and depending on their position and size of the fibroid, it causes blockages of the tube, as well as hindrance to sperm motility or sperm ascendance. Then endometrium causes like endometrial synecdoche, endometrial adhesions or infection to endometrium, as well as with this infection, this endometrium gets unsuitable for implantation. Then cervical mucus changes also causes infertility in few cases because of the infection. And by and large, we can see here this genital tuberculosis is one condition which is taking toll almost at every level, at the cervical level, ovarian, fallopian tube, as well as endometrium level. And in general, we divide these causes of the female infertility. Ovulatory causes will take toll of 25% cases, tubal factor, as well as pelvic causes will take 35% among each, and unexplained cases will be where there will be all factors are normal, but still it is infertility. So these are 5 to 10% of the cases. So coming to evaluation, one should always focus on couple while evaluating, not only one partner. As a gynecologist, we always stress more on evaluation of the female partner, but it is very important to focus on both partners, because most of the time we see patients, only female partner is coming along with either any family member, say will come to visit you, and we will start evaluating only female partner, but we should always ask male partner to join her, because if we are evaluating both as a couple, then we'll come to know what is their how is their compliance, what is their mentality, whether they really want to go for this treatment or want to get evaluated. Then both partners should be encouraged to attend each visit during evaluation to assess their attitude. While evaluating, we need to identify important underlying medical conditions so that we'll come to conclusion and we'll be treating those specific conditions so that we'll get success. So while evaluating, we should stress more on history taking. In this history, female age is very important, and which will decide our treatment direction, and definitely trying time, since how long they are trying, we should ask. Then detailed history should be elicited about menstrual history, obstetric history, any previous obstetric miss or any bad obstetric history, then any medical or surgical illnesses for which she is taking treatment, as well as chronic drug history. Then coital history is very important, because couple sitting next to you will be hesitating giving this particular history. So we need to elicit this particular history in detail. Then history of pelvic inflammatory diseases, sexually transmitted diseases, and thyroid illnesses, preferably in female partner. Then history of contraceptive used previously, because some contraceptives which are longer acting, after stopping those contraceptives, resuming normal ovarian cycles will take some time, and if those couple have already used such contraceptives, we need to ask history for that. Then environmental and occupational hazard. This history will be important male partner point of view, because male partner who are working near heated areas like boiler, furnaces, kitchen, or even driver sitting close to engine. So heated areas generally will increase temperature around scrotum, because testes in the scrotum are lying outside body, and main purpose of this descending of testes into the scrotum is because sperm production will be adequate or good in amount if our testicular temperature is 2 degrees Celsius less than core body temperature. So occupational hazard should be asked in detail. Then history of galactorrhea, hirsutism in female, gynecomastia in male should be elicited. Then addictions in couple should be asked, and family history of early menopause, because this history or this particular condition runs in family. So it's rightly said that if you listen to your patients, they are giving you diagnosis. So after history evaluation, we need to examine couple properly with general examination. In female, we need to examine thoroughly for completion. That examination will include breast examination, per speculum, and per vaginal examination. In husband, we need to ask for loss of smell, that is anosmia, which is significantly seen in Kallmann syndrome, that is hypogonadotropic hypogonadism. Then for gynecomastia, that is hyperandrogenism, and some genetic diseases like Klinefelter syndrome. And also need to examine external genitalia in detail. In external genitalia, we need to say penile examination. Where is this hymen? Where is this opening of the external meatus, whether there is phimosis, whether there is any other chordae or any other problems with pertaining to related to sexual activities. Then detailed examination of the scrotum for testicular size, testicular volume, its consistency, whether there is any scrotal cyst or epididymal cyst or testicular illnesses. Then palpation of the vas deferens is also important if we can. Then we will go through general investigations for both. And coming to specific investigations, we need for achieving pregnancy, we need to have one sperm, one egg, so that it will form embryo in fallopian tube and it will get implanted into the endometrium. So we need to have male gamete, female gamete, and uterus and fallopian tubes in good health. So coming to semen and sperm evaluation, it's proper evaluation is necessary. Semen analysis, which we do to see volume, seminal volume, sperm count, some sperm concentration, as well as quality of the sperms in detail. Also functional quality of the sperm is also evaluated. While doing semen analysis, one should exclude recent febrile illnesses. Also, collection of the semen sample should be by masturbation, which is ideal method if that couple is not willing, or if it is difficult by masturbation, then they are allowed to have sexual intercourse with use of male pack or condoms without any spermicidal jellies. Then about abstinence, actually 2 to 3 days of abstinence is enough. Many people, they think that if there is more number of days of abstinence, we will get more number of sperms. But actually, sperm concentration is one factor which will never change with any days of abstinence or volume. That sperm concentration will be always same. And with more abstinence, if this abstinence is more than 7 days, generally those sperms will get collected in the epididymis, and after 7 days, generally those older sperms will get damaged, or they will die, and they will secrete some toxic materials or reactive oxygen species, and that will damage further other new sperms, and it will cause DNA fragmentation of those sperms. So if abstinence is less, that is okay, but up to 2 to 3 days is optimum. Then analysis should be started after complete liquefaction. One should not do it in hurry, or one should not start analysis once collection of the sample is done. Then it is done in a well-equipped lab and with a dedicated technician to get proper result. And always one should keep in mind that motility and morphology are more important than only count. About CASA, that is computer assisted semen analysis, has hardly any benefit over the manual analysis, and manual analysis is actually widely practiced. So should we believe or rely on one semen analysis report? Obviously not, because there are some disadvantages of the semen analysis, and these are mainly like parameters vary from sample to sample, technician to technician, also lab to lab. So only one sample will not give you exact or correct idea. Also, normal report do not confirm fertility potential of that male partner. Also, conception is possible even with very bad sample, because we do not check semen analysis or check sperm quality of person who is having 3-4 kids, and man may be fertile to one female and infertile to other female. So after consensus, WHO in 2010 have set some low reference limits, that is like semen volume should be more than 1.5 ml, sperm concentration should be more than 15 million, total sperm number should be more than 39 million per ejaculate, then progressive motility more than 32%, and total motility should be more than 40%. Motility, that is live sperms in whole sample, should be more than 58% to say it is normal, and morphology by strict or Kruger criteria should be more than 4%. So when to go for chromosomal and genetic studies? It is mainly indicated in azoospermia and severe oligozoospermia cases only. And endocrine evaluation is done in abnormal semen analysis, where it is severe oligozoospermia and sexual dysfunctions like decreased libido or impotence. And this hormonal evaluation is in the form of follicle stimulating hormone and testosterone level. If total testosterone level is below 300 nanogram per DL, then we need to go with free testosterone, which is active form of testosterone, luteinizing hormone, and prolactin and thyroid hormones. So how to interpret these hormonal tests? If it is hypogonadotropic hypogonadism, all FSH, LH, and testosterone, all hormones will be low. If it is only abnormal spermatogenesis, FSH will be either normal or high, LH and testosterone will be normal. Testicular failure cases, there will be increased levels of FSH and LH hormone, and testosterone will be very low. In prolactin secreting tumors, there will be low to normal gonadotropins, that is FSH and LH. Testosterone will be low, and prolactin level will be particularly high. So what are imaging modalities we'll use in evaluating male partner? These are transrectal ultrasonography and transcrotal ultrasonography. Transrectal ultrasonography is done to detect ejaculatory duct obstruction, where patient with severe oligozoospermia or azoospermia cases with semen contain no fructose and vas deferens is palpable with low volume ejaculate, particularly volume of the ejaculate is less than 0.5 ml. Such cases, it will help in detection or diagnosing the ejaculatory duct obstruction. Transcrotal ultrasonography is done in cases where you are suspecting scrotal masses or varicocele, grading of the varicocele. So coming to specific investigation number 2, that is female gamete or oocyte or egg. You can see here matured oocyte with corona radiata around after denudation. This mature oocyte is seen, and this M2 oocyte, that is maturity level 2, and this M2 oocyte is mainly with the this extruded polar body is the indicator of the mature oocyte. So to evaluate oocyte or female gamete, we have test for ovarian reserve and test for ovulation. So coming to test for ovarian reserve, we have ultrasound marker as well as biochemical marker. Ultrasound marker, here we have antral follicle count, which is the important first test to come to know about fertility potential of that particular female. Here you can see this ovary is containing a few cystic spaces. These cystic spaces are nothing but growing follicles, and if these follicles are more than 5 in number in particular ovary, that particular ovary will be having good ovarian reserve. If both ovaries are having more than 5 numbers of the follicles, then this overall this female will be having good ovarian reserve. If those numbers are less than 5, then we will term it as a diminished ovarian reserve. And this particular ovarian reserve, generally we do to elicit this reserve, we do ultrasonography by transvaginal route, and it is done preferably day 2nd, 3rd, or up to 5th day of the cycle. Then coming to biochemical marker, that is anti-Mullerian hormone. It is hormone produced by small antral follicles which are less than 8 millimeter in size. After growing follicles, after the follicles grow beyond 8 millimeter, generally they will not produce AMH. It is a direct marker of the primordial ovarian follicular pool, or we can say it is a direct marker of the ovarian reserve which are in dormant stage. In female, it is undetectable at birth, while it will slightly increase slowly after birth and peaks at late puberty. And once that particular girl attain menarche, in that time this AMH level will be at peak, and it will slowly start decreasing and will be undetected after menopause. This will be exactly opposite in male. And about levels of AMH, one particular thing that it will be constant throughout menstrual cycle. It will not change according to days of the menstrual cycle. So it is advantageous over FSH and LH evaluation, for which we need to do only on day 2nd of the day 2nd, 3rd, or 4th of the cycle. So it is quite advantageous. So about factors affecting AMH, there are certain factors which will reduce AMH level. These are vitamin D deficiency, treatment with oral contraceptive pills. In obese female, this level will be comparatively less. Then smoking, tobacco chewing, past history of chemoradiation or chemotherapy or radiotherapy, then history of oophorectomy or ovarian surgeries in the form of cystectomy or ovariotomy. Then autoimmune diseases like thyroid illnesses and SLEs. Also, it will be high in some cases like polycystic ovarian syndrome, granulosa cell tumor of the ovaries. It is clinically significant in cases where it will give us idea about the premature ovarian aging, so that we can take early steps in treating those couple, or we can start treatment as early as possible. It will help us in diagnosing the polycystic ovarian syndrome cases where this AMH level will be more than 6.8, and even in certain cases this AMH level we have seen more than even 18, 19 also. It will help in predicting ovarian response in IVF stimulation protocols, whether it will be poor or hyper responders. Also, it will help in chalking out ovarian hyperstimulation so that we can prevent this complication related to hyperstimulation. Then egg freezing, social freezing, where this we come to know about ovarian rhizome, so that we can cryopreserve these oocytes and use later on in there after some time, and also helps in forecasting reproductive license, so that future preferences can be planned accordingly in career-oriented female. Coming to ultrasound marker for the ovulation test, we have folliculometry or follicular study, where we do serial ultrasonography, preferably transvaginally, and we start this transvaginal sonography from day 2nd or day 3rd of the period after baseline sonography. We'll call the patient after 5-6 days, and we'll do serial ultrasonography to know growth of the follicles, as well as the rupture of the follicle, as well as endometrial thickness, pattern, and we'll see when they are getting ovulated. There are some limitations with this, and these are mainly sometimes we may miss this follicular rupture or follicular collapse, and sometimes we will falsely label these ruptured follicles as a luteinized unruptured follicles. Coming to another test for ovulation, that is blood or biochemical marker, that is serum progesterone level, which we'll do on day 21 or day 21 of the cycle, or 7 days prior to presumed menstruation. This value will give us idea about confirmation of the ovulation if this value is more than 3 nanogram per ml on day 21, or if there are irregular cycles. In those cases, we'll do 3 evaluations and 3 blood tests, and we'll take average of those. If it is more than 3 nanogram per ml, then we'll consider it as a ovulation. We have other tests to predict ovulation, like basal body temperature, then cervical mucus pattern, as well as LH urinary kits. Also, we have available in market to predict ovulation. So after evaluation of male gamete, female gamete, next third specific investigation is uterus and fallopian tube evaluation. For this, we have various modalities in combination also, like ultrasonography, pelvis, then saline infusion sonography, laprohistro, and evaluation of the endometrium for tuberculosis. This ultrasonography, it is ideal to do transvaginal sonography with transabdominal sonography with the help of 2D and 3D probes, so that it will give us idea about the uterus, myometrium, endomyometrial junction, endometrium thickness, pattern, its blood supply. Then also it will give us idea about any pathology related to tubes or ovarian reserve, as well as any ovarian abnormality. Then about fallopian tubes, we have to assess fallopian tube patency, we have either SIS or HSG. HSG, which is age-old technique, we do commonly use this, and this hysterosalpingography is done to assess patency of the tubes. We do this test on after stoppage of menses, after 2 to 5 days of the cessation of menses, and it is done with use of radio-opaque dye, and we'll take serial X-rays to know about patency of the tubes. Here it is HSG picture, where we can see here a dye which is coming out of the tubes, and get spillage is seen in the pelvis, and it is the confirmatory test for tubal patency, as well as it will give us idea about the uterine outline, so that any intrauterine pathology will also, or any filling defects will also be come to know. Here, this picture will give us idea about the uterine inner inner part of the uterus or uterine cavity, and here you can see these tubes are not patent because spillage of the dye is not seen, but this dye is getting collected into the fallopian tubes because of this blocked tubes at the femoral end, and this is also called as hydrosalpinx. So coming to next modality for tubal patency, like HSG, we have SSG or saline sonosalpingography or SINE test. Here, instead of using radio opaque dye and X-rays, we can here use ultrasound with normal saline only. We do this test like same day like HSG. Instead of using Leach Wilkinson, will use either SINE catheter or number 8 Foley's balloon catheter, Foley's catheter with balloon distended with 2 cc saline, and will infuse saline into the cavity and observe saline passing through both tubes. Just to improve this visibility, we'll put either Doppler or we'll use double contrast, that is air saline or EcoVist to improve our visibility or its sensitivity. So it is this SSG or SIS is even more accurate than HSG, as well as it will help in assessing endometrial thickness, pattern, as well as subendometrial blood flow, which is advantageous over HSG, because this SSG is a real-time study. So definitely it is preferentially used by many people, and nowadays it is almost about replacing this HSG. These are some pictures of SIS or SSG, which is giving us idea about intracavity pathology, as well as hydrosalpinges is seen in ultrasound picture. So coming to uterine assessment for infertility purpose, we need to stress on uterine structure, intracavity structure, as well as endometrium. In uterine structure, that is myometrium, we need to see whether there are any congenital uterine abnormalities which are leading to this condition. Then fibroids, their number, their size, as well as their position, and if there is any submucous fibroids, then adenomyoma, whether it is at focal or diffuse adenomyoma, and generally bulky ovaries, bulky uterus with distended cavities due to adenomyosis generally affects sperm ascending moment. Then intracavity pathologies like endometrial polyps, endometrial adhesions like Seineke, as well as submucous fibroids, if they are there, we need to evaluate. And evaluation of endometrium, which is very important, in the form of endometrial thickness, endometrial pattern, as well as at the molecular level, we need to do some histological evaluation in the form of any bacterial culture or endometritis panel to rule out endometritis or inflammation of the endometrium, as well as if there are recurrent implantation failure, we need to go with some molecular structure assays like endometrial receptivity assays and other tests to assess functionality of the endometrium. With this ultrasound, if we are using a 3D probe, we'll come to know about the size of the uterus, its position, as well as the endometrial cavity, whether there are any pathologies or uterine abnormalities we can detect properly, so that we'll come to know about particular reason for infertility, as well as also it is helpful in rule out causes of repeated pregnancy losses. So the endometrium, which is a very important factor. So while evaluating, one should stress more on endometrial thickness, endometrial pattern, whether it is type A, type B, or type C, depending on their types. And these are mainly because of the hormonal effects on the endometrium. These chances of pregnancy is also varying with this pattern. And most important is vascularization. We need to assess whether this vascularity is up to zone 1, 2, 3, or 4. Depending on those, these chances of pregnancy also changes. So this endometrial thickness pattern and its any abnormality related to endometrium, we need to evaluate or assess properly. So coming to laparoscopy and hysteroscopy, this laparoscopy hardly has any role in evaluation, but to rule out certain abnormalities related to uterus, any adnexal pathologies, or to correct some adnexal pathologies, we need to take help of laparoscopy, as well as some intracavity lesions like endometrial polyps, fibroid polyps, or submucous fibroids, intrauterine adhesions, or thin endometrium. We need to take help of hysteroscopy, as well as we saw this one video nicely shown by Dr. Amol sir, where we cut this complete septum with Collins knife, and it was very good or rewarding surgery, which generally gives us success in infertile as well as repeated pregnancy losses cases. And laparoscopy generally will give us idea about, or it is mainly used when there are certain adnexal pathologies. So to take home message from this, one should stress more on evaluation of both partners rather than evaluating one partner, and always start evaluating male partner, because doing semen analysis is comparatively easy, and one good semen analysis will give us idea about male partner, while proper history physical examination is also key to arrive to diagnosis. And while treating, we need to consider factors like female age, antral follicle count, and anti-Mullerian hormone level in that female. Also, do not forget limited fertility or reproductive period for female, so that we need to start treating accordingly, because we do get many patients who are doing IUI again and again, one place 2 IUI, other place 2 to 3 IUI, and then later on we come to know that with this so many IUIs, they have exhausted their ovarian reserve, and now they have hardly few eggs remaining. So depending on their cause, we need to go, or depending on age, AFC, AMH, we need to start treating. So if we could evaluate them properly, we will definitely come to one diagnosis, and it is easy to treat those cases, as well as definitely we will get success in such cases. Thank you.
तो मैं क्या करूं? ठंडा पानी नहीं है ना?
Questions?
Yeah, thank you, sir. Thank you for your wonderful talk. Dr. Diksha, I'm going to read out the questions.
Yes. So we do have some questions for Dr. Gaikwad. Is there any other way of management for patients with repeated miscarriages and diabetes mellitus and hypertension? Is there any different approach?
The approach, as Dr. Amol sir discussed in his lecture, he has nicely depicted all causes for recurrent miscarriages, that is RPL cases, and we need to follow almost same, like proper history taking, then general examination, as well as whatever causes we can elicit accordingly, like what he suggested, endocrine causes, any genetic causes, any anatomical causes, we need to evaluate in recurrent cases, recurrent implantation or recurrent pregnancy losses cases.
Okay. Dr. Amol, there's a question for you. Do you have you, Dr. Amol? Does teratozoospermia cause infertility?
Yes, teratozoospermia can be a reason for infertility. Definitely, Dr. Ramesh in his lecture has clearly shown that the male factor has to be evaluated by a proper semen analysis, and teratozoospermia can be one of the cause for infertility, because if the sperm are highly defective, then this sperm will not be functional enough to cause proper fertilization and result into a good pregnancy. So teratozoospermia can not only be a reason for infertility, it can also be a reason for recurrent pregnancy losses also, especially if they are associated with very high sperm DNA fragmentation index. So, and that is why in while doing a good semen analysis, we should not only look at the count motility, but also in detail about the morphology. And the morphology has to be evaluated by the strict Kruger's criteria. And we know that maximum sperms in human species are going to be defective. So according to the recent WHO guidelines, 4% of the sperms are usually normal in a normal semen sample. So that one should be aware of.
Okay, sir. Okay, sir. There's one more question. Is there any relation between insulin resistance, endometriosis, and PCOD? And what are the options for conception in these cases?
So yes, definitely there is relation between insulin resistance and PCOS. Regarding insulin resistance and endometriosis, there is no direct relationship as such because the reasons of endometriosis can be varied. And mainly, basically, it is conclusively proven that insulin resistance and PCOS most of the times will go hand in hand. And therefore, as in my lecture with recurrent pregnancy loss, we have clearly shown that treating patients with PCOS, getting their hormonal milieu right, treating the insulin resistance, lifestyle modification, weight loss, will all going to help these couples to sustain their pregnancies. Now, endometriosis is altogether a different etiology and a different etiopathogenesis. And according to the all the factors, we will have to treat that couple accordingly.
Okay, sir. Okay, sir. So there's a question by a general surgeon, Dr. Sandeep Naik. He has noticed that ejaculatory duct obstruction detected by transrectal sonography is restricted to cysts only and are very rare. So generalized stenosis, usually bilateral, is difficult to detect and treat. So what have you noticed something like this in your experience?
Basically, ejaculatory duct obstruction can be one of an important reason of obstructive azoospermia. And in those cases, basically, we will have to go, if there is no sperms in the semen, then the way out for pregnancy is to use epididymal or testicular sperms and achieve pregnancy.
Okay, so is it asymptomatic? Are there any
it can be asymptomatic. It can be asymptomatic. There can be certain symptoms like hypospermia, overall semen volume might be less, and ejaculation might not be that proper.
Okay, sir.
Prostatomegaly cases, sometimes we do get or we come across such problems, ejaculatory duct obstruction. So transrectal ultrasonography will help in evaluating that.
Okay, sir. I think that's all from the question and answers session. Just see for last check. Any more questions?
Dr. Ramesh has to remove his share screen.
Yeah, sir, you can stop sharing your screen. Yeah.
So yeah, that's all from question and answer sessions. So I would, hello?
Yes, yes.
Yes, you're audible.
So I would like to thank Dr. Amol Lunkad and Dr. Ramesh Gaikwad for generously explaining this topic and sparing their time for this evening for us today. Thank you, Dr. Ramesh. Thank you, Dr. Amol. Thank you, Dr. Abhishek Thakur, for helping us with this CME and for all the time you spent.
We have one more topic now after this.
Yeah, actually, there is one more topic.
Okay, sir. So sorry about that, sir. So you can start with the next topic, sir.
Yes, so basically after looking after, as Dr. Ramesh has nicely evaluated and told us about the evaluation of an infertile couple, let us in short look at how to manage these infertile couples. So the final topic is regarding A to Z of infertility management. And once again, I thank you all for with Goa IMA. And as Dr. Ramesh has uh, nicely told us about evaluation, the most important thing is all infertile couples should be evaluated properly at the first hand itself, so that we come to know about their problems, about the etiology, and as we find the problem, so shall we treat, and that would give us accurate and consistent results. So after proper evaluation, let us look at the treatment options, and the treatment options can be varied, right from simple lifestyle modification to ovulation induction to assisted reproductive techniques like IUI, IVF, ICSI, and advancements in ICSI. So there can be a range of treatment right from simple lifestyle modification to surrogacy and donor egg programs and so on and so forth. So the aim basically is to convert this education and knowledge into action so as to help fertile couples achieve healthy pregnancies and healthy live births. So let us look at all these options, right from simplest lifestyle modification to the most recent and advanced treatment options. Lifestyle modifications, as we all know, simple weight loss will cause almost 90% obese anovulatory females to ovulate. So weight loss, diet, exercise is an important part of infertility management because lifestyle modification and weight loss will not only decrease the androgen levels, it will increase the sex hormone binding globulin levels, it will decrease the insulin levels, and insulin resistance would decrease, insulin sensitivity would increase, and so the long-term effect would be improved ovarian function, improved ovulation, and improved chances of achieving pregnancy. The other than lifestyle modification, the most commonly used modality for treatment of infertility is ovulation induction. And ovulation induction is nothing but converting an anovulate, helping her to ovulate by use of various modalities, or making a already ovulating female super ovulate, so her chances of achieving pregnancy increases. So ovulation induction is basically use of pharmacological agents to convert an unovulatory or improperly ovulating female into a ovulatory female, or an already ovulating female, we help her to super ovulate. Overall, the modalities used for ovulation induction can be oral agents, injectables, or a combination of these, and there can be certain adjuvants which can be used. The oral agents which are most commonly used are clomiphene citrate or aromatase inhibitors. Injectables which are used are human menopausal gonadotropins or follicle stimulating hormones. We can use a combination of oral agents and injectables. These are the widespread various uses of various agents which can be used for ovulation induction, but let us look at few of them which are important and commonly used in day-to-day practice. Clomiphene citrate, we all know, is a selective estrogen receptor modulator. It is the most common oral ovulation or ovulation induction drug which is used, and it is used for the last 6 decades or more. And it is a racemic mixture of enclomiphene and zuclomiphene, enclomiphene being the more potent with shorter half-life. So it causes ovulation in 70 to 90% patient, but the pregnancy rates are less, almost in 30 to 40%, because of the anti-estrogenic side effects of clomiphene on the cervical mucus and on the endometrium, causing thinning of the endometrium and thickening of the cervical mucus, thus reducing the pregnancy rates. How we use clomiphene citrate? We do a baseline sonography on day 1 or day 2 of the cycle. Baseline sonography is important to rule out any leftover cyst of previous cycle, any luteinized unruptured follicle of previous cycle. We also come to know antral follicle count. We also come to know about the endometrium and the adnexa. So the baseline scan is important, and many times I see practitioners do not do a baseline scan and directly do a follicular study on day 10 of the cycle. So we have missed out so many things if we do not do a baseline scan. So a baseline scan is important. Then we start with the oral ovulation clomiphene citrate. Either we start on day 2 of cycle, or we can start on day 3, 4, or 5 of the cycle. Also earlier is usually better, so that you can use the rest of the days to add on with the injectables if required. Overall, we give it once daily for 5 days, and we usually start with a dose of around 50 mg. You can use incrementally in the subsequent cycles and go up to even 150 to 200 mg. You then follow the follicular study and look for dominant follicle formation and see if ovulation is occurring or not. Or you can trigger ovulation once the follicle reaches a size of 20 to 22 mm and the perifollicular vascularity is good, then you can trigger ovulation also. Now the other oral agents which can be used, one is very good, is tamoxifen, especially in those patients who are having thin endometrium on clomiphene citrate. There you can think of using tamoxifen, because it is again a selective estrogen receptor modulator, but it will not have the anti-estrogenic side effect of thinning of the endometrium as seen with clomiphene citrate. Used in a dose of 40 milligram to 80 milligram. It is basically will give a similar ovulation and pregnancy rate as clomiphene citrate. Aromatase inhibitors are the agent of choice nowadays. They are widely used nowadays, and especially they have become the first agent of choice in patients with PCOS, because they will give more or less a monofollicular development, will not cause hyperstimulation. Second thing, they will not have thinning of the endometrium, and they will also not cause thickening of the cervical mucus. Aromatase inhibitors act by inhibition of the aromatization tissue. So the conversion of testosterone to and androgens to estrogen is inhibited, and as this is inhibited, the estrogen levels go down. As the estrogen levels go down, the negative feedback of the estrogen to the hypothalamus and the pituitary is reduced, and so more FSH is released by the pituitary, and so more follicles are recruited. This is how aromatase inhibitors act. And third generation aromatase inhibitors like letrozole, anastrozole are commonly used. Especially letrozole is the most commonly used drug now. And as I said, the advantage is reduced hyperstimulation, no anti-estrogenic side effects, and overall a better safety profile. Gonadotropins we can use, which are injectable, which act directly on the ovaries and stimulate the ovaries directly. They can be human menopausal gonadotropin or recombinant FSH or recombinant LH. They can be used alone or a combination with oral agents. Overall, the advantage of gonadotropins is basically they act directly on the ovaries and give very good response. The overall one thing which should be as a take-home message is, whenever we add gonadotropins, we have to be very, you can say, closely monitoring the patient. Very close sonography monitoring is required, so that the patient do not land up into hyperstimulation. How will we decide the dose of gonadotropins? Will depend on various factors, that is the age, the AMH, the antral follicle count, and the BMI and her previous response. So all these 5 things have to be taken into consideration to define the dose of gonadotropins. There can be various protocols which are used for gonadotropin use. It can be a step-up protocol, a step-down, or a combination with oral agents. Most commonly used is the slow step-up protocol, but the aim is fixed. The way we achieve it can be different. The aim is to convert an anovulatory female into an ovulating female, or an already ovulating female, and make her superovulate, form 2-3 eggs, so that her chances to achieve pregnancy increases. Now, after giving gonadotropins or oral agents, once we get dominant follicle formation, we can trigger ovulation by using HCG or GnRH agonist. Now, HCG is a surrogate of LH, so giving HCG will cause a LH surge and thus result into ovulation. So, trigger can be used we can also wait for natural ovulation, or we can use trigger. Whenever we are going for timed intercourse or whenever we are going for IUI, usually we prefer trigger. So certain patients you can leave for timed intercourse, that is once the dominant follicle formation is there and follicle size goes above 14 mm, we will tell the couple to have at least alternate day intercourse. And we can also think of going for IUI. We'll see regarding IUI further. Certain adjuvants can be used, especially in patients having insulin resistance, glucose intolerance, or severe PCOS. There we can use metformin or myo-inositol. Metformin is not to be used for all patients or all infertility patients. We can use certain antioxidants also, like coenzyme Q10 and vitamin E. Regarding trigger, we have already seen. So one take-home message for trigger is trigger should be given not only according to the size of the follicle, but also according to the vascularity of the follicle. So looking at the perifollicular vascular flow, or the Doppler, is also very important. Coming to IUI or intrauterine insemination. IUI or intrauterine insemination is a, you can say, basically a procedure wherein you are depositing wasp spermatozoa directly into the uterus above the level of internal os around the time of ovulation, and you are overcoming the vaginal acidity, you are overcoming the cervical mucus hostility, and this direct deposition of highly motile sperm, morphologically normal or better sperm, directly near the fertilization site will help the couple achieve pregnancy. So this is the overall gist of using IUI or intrauterine insemination. So once you have stimulated the patient, given ovulation induction, one can add on with IUI. Let us see what are the indications of IUI. Any patients with coital problems, having erection, ejaculation issues, or where there is basically cryopreserved sperm in case of cancer patient, or cryopreserved semen sample, there you can think of using IUI. Or those patients where there is a mild to moderate male factor infertility. So mild to moderate oligospermia, mild to moderate asthenospermia, or mild to moderate teratospermia, we can think of using IUI. For IUI, the total motile sperm count has to be at least more than 2 million, and better if it is more than 5 million. So patients where the total motile sperm count is between 5 to 10 million, there IUI can be used. Of course, the tube should be patent and there should be proper ovulation for IUI. Now, the steps involved in IUI are ovarian stimulation by the use of oral agents or gonadotropins, or a combination of these two. We monitor the follicular growth, the endometrial development. We basically trigger the ovulation, and then we time the insemination. You can do a single IUI or a double IUI. A single IUI usually 36 hours after trigger, double IUI is 24 hours after trigger, the first IUI, and second IUI would be 48 hours after trigger, after confirmation of ovulation. Usually in IUI, we do semen wash, and the wash is either by a swim up method or a density gradient method. Usually most commonly used is the swim up method, and then the IUI procedure is done and luteal phase support is given. So it's a simple process, and a simple procedure does not require any anesthesia. And overall, the success of single IUI cycle with all the parameters being up to the mark will be somewhere around 18% to 20% or so. Coming to advanced treatment modalities like IVF in vitro fertilization, we know the first IVF baby of the world came into being on 25th July 1978, and this historical event was brought to us by Dr. Steptoe and Dr. Edwards from London. And the mother of Louis Brown had both her fallopian tubes blocked, and as both the fallopian tubes were blocked, Dr. Steptoe and Dr. Edwards thought that wife's good eggs or oocytes and husband good sperm are never going to unite because the tubes are non-functional. So the only way out for her to achieve pregnancy will be the unification of these gametes outside, in vitro, in laboratory, in proper environment. so that once the fusion of the eggs and sperm is done outside, the embryos which are formed can be reposited back into the uterus to achieve pregnancy. And this is the concept how IVF came into being. This concept of unification of gametes in vitro, in laboratory, in proper environment has been now used for various other indications over the last 42 years. The indications have ever expanded, and more than 85 lakh IVF babies have come into being in this world. So this historical event of the first IVF baby on 25th July 1978, India was nowhere behind at that time also. The world's second IVF baby and Asia's first IVF baby came from India by the work of Dr. Subhash Mukherjee and his colleagues in Kolkata, and Kanupriya Agarwal alias Durga was born, uh, India's first IVF baby and world's second IVF baby. So the overall technique of IVF in 1978, the eggs were retrieved outside, and these eggs were exposed to few thousands of sperm in a petri dish in a controlled environment, and the eggs and the sperm were left to unite for next 12 to 24 hours. But in certain cases, fertilization rate still remained low, and even after doing so much, the eggs and the sperm were unable to unite in many cases, especially where there was severe male factor, where the sperm count was too low, where the motility was very less, where the sperm had poor acrosomal reaction, where the sperm were globospermic. So in severe male factors, the fertilization remained quite low. Even in certain cases where the sperm were good, there were certain factors in the oocyte which did not allow fertilization. So in 1992, ICSI came into being, wherein each good egg was directly injected with one good sperm. So under the microscope, under 400 times magnification, the inverted microscope, each mature egg was directly injected with one good sperm. You can see here in this video ICSI being done live, and this is a mature egg. We come to know that the egg is mature by this polar body which is extruded at 12 o'clock position. Now each mature egg is held by a holding pipette at 9 o'clock and an injecting pipette at 3 o'clock, injecting one mature sperm directly into the nucleus of the egg to fuse each good egg directly with one good sperm. Here you can see the sperm being injected directly into the nucleus of the egg. This is how the gametes are unified, or the fertilization occurs directly under the microscope, and each good egg is injected with one good sperm. Because of ICSI, the fertilization rates improve and overall success also improved in several cases, and more indications add the advancement of ICSI. ICSI, how and when, what are the steps involved, and what are the indications? The steps are very simple for IVF or ICSI. We do controlled ovarian hyperstimulation, which is same as we saw. Then once multiple eggs are formed, so we give gonadotropins, and these gonadotropins are given in higher dosages to form multiple eggs. Here you can see this video. After giving controlled ovarian hyperstimulation, multiple eggs would be formed. These eggs would be aspirated under transvaginal sonography guidance, transvaginally using a 17-18 gauge needle. The other end of the needle is attached to aspiration pump, and by creating a negative suction, these eggs would be aspirated transvaginally. Here you can see a transvaginal probe along with the guide and along with the aspiration needle going inside and aspirating the oocyte. Along with the follicular fluid will come the mature egg outside. So these oocytes are aspirated, and the oocyte cumulus complexes will come outside along with the follicular fluid. These eggs would then be you can exposed to the sperms, or each good egg would be injected with one good sperm to form zygotes and then embryos. The embryos would be grown for 3 to 5 days. Those embryos which grow very well would be then reposited back into the uterus to achieve pregnancy. The aspiration of the eggs is done under short general anesthesia. And the embryo transfer or depositing back the embryo into the uterus is a simple process. It does not require any anesthesia. Here you can see embryo transfer being done under transabdominal sonography guidance. These embryos are reposited back into the endometrial cavity by a simple slender embryo transfer catheter. The embryos will go and attach to the endometrial lining and implant the endometrial lining and start growing to give a pregnancy. This is how IVF is done, and it involves mainly 4 important steps: pre-assessment of the couple and counseling, followed by control ovarian hyperstimulation, followed by ovum pickup and fertilization with ICSI, followed by embryo transfer and post-embryo transfer counseling. So these 4 simple steps and IVF is done. So the indications of IVF for ICSI, as I said in the beginning, the IVF started for those couples who had tubal problems because the mother of Louis Brown had both her fallopian tubes blocked. But the indication expanded in the last 42 years to several other indications, and let us see those in short. Male infertility, moderate to severe oligozoospermia. We saw mild to moderate oligozoospermia or asthenozoospermia, we can think of doing IUI. So total motile sperm count more than 5 million, especially total motile sperm count, if it is less than 5 million or especially less than 2 million, then ICSI is the only way out. Obstructive azoospermia. So in cases of obstructive azoospermia, as Dr. Ramesh has already shown us, that there would be sperm in the semen, but there would be no, there would be sperm in the testes, but there would be no sperms in the semen. So in obstructive azoospermia, the testis is functional. The testis is producing sperm, but there is no sperm in the semen. So we will have to extract the sperm from the testes, what is known as testicular sperm extraction or epididymal sperm extraction. And we will have to fertilize these sperms along with the eggs which are retrieved from the wife's ovary. So the eggs and the sperm would be united or fertilized outside in vitro by ICSI, and the embryos so formed can be reposited back into the uterus to achieve pregnancy. So those males who are having obstructive azoospermia or who want to achieve pregnancy after vasectomy, testicular or epididymal sperm extraction along with ICSI is the best way out. Those males who are having retrograde ejaculation, taking urinary sperms after alkalinizing the urine or taking testicular sperm is the best way out to achieve pregnancy for them. Coming to the female reasons of indications of IVF for ICSI, we saw fallopian tube blockages or hydrosulfings or pyosulfings. Other indications can be PCOS patients not responding to usual treatment. So in certain PCOS patients who are severe PCOS, they do not respond to usual ovulation induction drugs, usual small dosages of gonadotropins, and whenever dominant follicle formation happens, they directly go into hyperstimulation. In such patients, the best way out is to stimulate them with proper gonadotropins, form multiple eggs, retrieve these eggs after giving a GnRH agonist trigger, forming good embryos and freezing all the embryos, and then going for a frozen embryo transfer cycle later. So that is the best way out. Endometriosis, adenomyosis, we know this will cause distortion in the tubo-ovarian relationship. This will cause distortion in the pelvic anatomy, and thus the egg and the sperm are not able to unite. So this unification has to be done artificially. Failure of 3 to 4 IUI cycles. So if there is failure of 3 IUI cycles or 4 IUI cycles, the subsequent IUI cycle just has a success of around 8%. So that is why wasting the ovarian reserve for such low success is not advisable. In spite of doing IUI, the oocyte and the sperm are unable to unite. So we will have to make this unification happen artificially by doing ICSI. Premature ovarian failure, females with postmenopausal females wanting pregnancy, then egg donation IVF technique is the only way out. Unexplained infertility, not responding to usual treatment, again IVF for ICSI is the best way out. And those couples who have tried simpler forms of treatment for 2 years or more and still not achieving pregnancy, they should also go for the advanced treatments like IVF or ICSI. Certain patients with recurrent pregnancy losses who are having translocation, inversion, who are having mosaicism, or those who are having various genetic disorders in their family like thalassemia, sickle cell anemia, BRCA mutations running in the family, who are having hemophilia or having, you can say, various genetic disorders, they can basically form embryos outside, check each embryo for various genetic disorders. They can check each embryo for its euploidy, that is, the embryo is genetically normal or not. And if we reposit back a genetically healthy embryo, then overall chances of achieving pregnancy, overall chances of achieving a healthy pregnancy, overall chances of preventing a pregnancy loss are going to be much, much better. So repositing back a genetically healthy embryo can be done by forming embryos and checking each embryo for its genetic makeup, what is known as pre-genetic testing or pre-genetic diagnosis. Certain patients who are serodiscordant couples with HIV. So nowadays, nobody is, you can say, hardly anybody is dying of HIV. The drugs are very good, they are highly effective, they are freely available. So now more and more HIV couples or serodiscordant couples want to achieve pregnancy, and most of them would require help to achieve pregnancy. And so they come to us for IVF ICSI treatment. Let us in short also look at various advancements in the ICSI treatment which has occurred. After ICSI, we also have IMSI, which is using higher magnification. In ICSI, we are using 400 times magnification. In IMSI, we can use a magnification up to 6,000 times. So we can select a morphologically better sperm. If we select a morphologically better sperm, then overall chances of achieving pregnancy or achieving healthy embryos is going to be far much better. We can sort the sperm. So we have various techniques for sperm sorting. We have microfluidic sperm sorters, we have magnetic sperm sorters. The concept of sorting the sperm is to differentiate the best sperm having the best motility, the best morphology, the best head, and the least fragmented DNA from those which are, you can say, poor sperms. So if we can sort the best sperms and use the best sperm to achieve healthy pregnancy, then overall conception rates and overall healthy pregnancy rates would be much, much better. We have blastocyst culture. So as I said, when we culture the embryos, embryo first day would be a 2-cell embryo, second day it will be a 4-cell embryo, third day it will be 8-cell embryo. If we keep on culturing the embryos for 5 to 6 days, on 5th day it would form a blastocyst. These are the best embryos because if it is growing very well for 5 days, then the embryo has shown its robustness, it has shown its, you can say, quality, and so these such robust embryos are more likely to give a better pregnancy. So instead of keeping less robust and more embryos, world has now moved for transferring or keeping, you can say, more robust and less embryos. So people do not want multiple pregnancies, 3, 4, 5 pregnancies. They want a single healthy pregnancy. And that is why blastocyst culture is a very good advancement. It will help us to keep less embryos but more robust embryos by this extended culture. And for this extended culture, we use these benchtop tri-gas incubators, and laser assisted hatching is one of the important advancements. So in IVF or ICSI, so many patients, even after transferring good embryos, the implantation does not occur. And to improve implantation, we can help the embryo at the level of the hatching stage by doing a laser assisted hatching. So 10 to 15 minutes before transferring the embryo into the uterus, we thin out the shell of the embryo from one side, so the energy of the embryo can be conserved while it hatches out, and so it has more energy left with it to implant and to give better pregnancies. So many times, due to age, due to culture conditions, and due to various other factors, the outer shell of the embryo is hard or thick, and so the energy of the embryo gets wasted in coming out of this hard and thick shell, and so it has left less energy with it to implant. So if we can help that stage, implantation would improve. This is laser assisted hatching. Many cases with implantation failure, it would improve the implantation rates by almost 25%. This is here you can see the laser assisted hatching being done live under the inverted microscope under a magnification of 400 times. Here this you can see a blastocyst embryo, and the outer zona or the outer shell of this embryo before transfer would be thinned out. This is a case of recurrent implantation failure. We have done blastocyst culture and we used laser shots to thin out the shell of the embryo from one side. So the embryo will require less energy while it comes out of the shell and gets attached to the endometrial lining. This is the line along which the laser shots would act, and now you can see the laser shots acting 1, 2, 3, 4, 5, and 6. So this will cause the thinning of the outer zona and help better hatching and better implantation. Embryo biopsy we have already seen. We can check the embryo genetically. This is one revolutionizing advancement where we can take out few cells of the embryo. Here it is a 8-cell embryo. We are taking out one cell. Usually what we do is a you can say blastocyst biopsy. Here you can see we have sucked out. So using the laser, we have taken a hole in the zona. We have sucked out few cells, and then using the laser, we will detach these cells from the embryo. These cells would be cultured and then genetically checked. If that genetic checking shows the culture to be normal, then the embryo from which these cells have come, that embryo is genetically normal, and such healthy genetically normal embryos, euploid embryos, will give a much better pregnancy. Here you can see the embryo biopsy being taken. So all patients who are having genetic disorders running in family, who are having higher age, and higher age, we know the chances of Down syndrome, mental retardation are going to increase. So if you want to ensure that we are putting a genetically healthy embryo into the uterus, then pre-genetic testing or pre-genetic diagnosis is the best way out. If we are repositing a genetically healthy embryo, then the overall chances of achieving a healthy pregnancy is always going to be much, much better. The next advancement in IVF or ICSI is the cryopreservation or vitrification. And this one advancement has turned, or you can say, has revolutionized the way IVF was being done in the last 2 decades or so on its head. We can freeze the sperm, we can freeze the eggs or the oocyte, we can freeze the embryos, and we can freeze the ovarian tissue and the testicular tissue also. You all physicians or family physicians or practitioners or you can say specialists and super specialists in your own field should know that any patient who is having any cancer, is detected with any cancer, or is going to undergo chemoradiation for various illnesses and has not completed his family, you can freeze his gametes, because once he undergoes chemoradiation, his gametes are fired for years together. If they have frozen their gametes prior, they can use them once they are free of cancer and achieve pregnancy with their own gametes. Many times, while undergoing through chemoradiation or cancer treatment, patients are in overall distress and they do not think of reproduction and fertility that time. But it is our responsibility to guide them. A simple semen freezing done before a testicular surgery or a cancer chemoradiation or chemotherapy can easily save his fertility. Semen freezing is very easy. Hardly any cost is involved. Similarly, egg freezing is also very easy. Of course, egg freezing is little costly. Overall cost of egg freezing goes to somewhere around 1 to 1.25 lakhs. And most important thing is these gametes, these embryos can be frozen for years together. So any female who is, due to her career, due to her education, due to her you can say profession, not wanting to have pregnancies, not wanting to have you can say marriage, or no, due to social reasons she is not wanting to have you can say pregnancy, then she can freeze her gametes, she can freeze her eggs, she can even freeze her embryos if her marriage is already done or if her partner is fixed. And those females who are having a family history of premature ovarian failure, they can also think of egg freezing. Males who are having ejaculatory and erection problems and undergoing infertility treatment, they can freeze their semen. Extra embryos can be frozen in an IVF cycle for achieving next pregnancies, or that would also increase the cumulative success of IVF a greater extent. After looking at various advancements in the techniques, let us look at various advancements in the instrumentation. These are stereozoom microscope. This is an inverted microscope which is used for looking at the oocyte, looking at the sperm. Fertilization of egg and the sperm is done under the inverted microscope. Injecting each good egg with one good sperm is done under this inverted microscope. And these inverted microscope are being used in open in an outside environment. So instead of that, a closed working chamber IVF technology is one more advancement. And Indra IVF was the first to bring this technology of closed working chamber to India in 2011, and we started using them in India. The original chambers were imported from Australia. 2015, we started making these chambers in India itself, along with Shivani Scientific by the name of LabCell. And this closed working chamber will give a similar environment to the egg and the sperm and the embryo when it is formed, as they should have received in the mother's womb. So similar oxygen saturation, similar temperature, similar carbon dioxide saturation. So if we give the best environment, the embryos form would be better. If the embryos are better, the overall success of IVF would improve. The incubators have gone a transition from the traditional fridge-like incubators to the benchtop tri-gas incubators with the embryoscopes, where you can give the best environment and no need to disturb the embryos for the 5 days when they grow. You can give the best environment and you can check for the growth without disturbing the environment whenever you want. RI witness, electronic witness technique is one of the important advancement in instrumentation. You can say all embryos, all gametes, sperm, oocyte can be electronically barcoded with the use of RIFD technology, and so not only to the patient but also to the embryologist and the doctors, and there is no chance of any human error. Again, Indra IVF was one of the first to bring this technology to and starting using it in India, and all our centers have the RI witness technology now. So we have looked at various treatment options and various advancement in these options. Let us look at the success of ART as a whole, and the success depend on various factors, right from the factors involved in ovulation induction and control ovarian hyperstimulation to the male factor, to how the embryo quality was, how the embryo transfer was done, and certain factors which act at the implantation level. So all these factors determine success. I am just going to show you the glimpse of our ART success at Indra IVF Pune. So it is more than 17,000 cycles with a success of 77.4% or so, and abortion rate of around 12.2%. Various duration of infertility and various indications of infertility. And my team at Indra IVF Pune, we are 8 IVF specialists, 2 fetal medicine consultant, and 1 andrologist, sexologist, and a team of 8 embryologists working. So this is our center at Indra IVF Pune. Most of you must have had patients or have interacted with our patients or known about this center. So I have tried to basically take you through various treatment options and A to Z of infertility management, right from the simplest form of treatment to the most advanced ones. Thank you for your patient listening, and thank you all for giving this opportunity. Thank you again, Goa IMA and IMA Bardes for making this possible. Thank you, MQR, for being the academic partners. And just one joke at the end to this slide is showing that one thing that Amazon cannot you can say deliver at home is a baby, but maybe advancement in techniques and technology would make it possible. That also because our IT couples from Pune, they are not having that much patience to go through all the evaluation and take so much of treatment. They will just want to basically order a baby on the app and have it. So nowadays couples hardly have that much patience to go through so much of you can say evaluation and treatment. So just ending with.
Thank you so much, sir. That was an amazing lecture. With all the animations, it was beautiful, sir. There was one last question which was asked by our Dr. Amit Trokade. You had one of the slides that mentioned occupational causes for infertility in females, sir. Was it right? What could be the occupational causes, sir?
So various occupational hazards which are causing them to expose to radiation, to we know that exposure to chemicals, radiation is going to affect the female's ovarian reserve, and if that may cause premature ovarian aging, and that would also result into infertility. Occupational hazard is especially important to the male counterpart also, because exposure to heat, exposure to again chemicals and radiation will affect the sperm count. We know those working in furnaces, those working in high heat environment, those who are cooking in high environment, welders who are working in high heated environments, they will have a poor sperm count. So both male and the female counterpart can be exposed to various occupational hazards, which will result into infertility. Exposure to anesthetic gases in high amounts and repeatedly can also result into pregnancy losses in the early first trimester. So all these things have to be taken into consideration.
Okay, sir. Okay, sir. Thank you for elaborating on that. So thank you, Dr. Amol. Thank you, Dr. Ramesh, for such an amazing presentation, for guiding us. Thank you, Indira IVF. Thank you, MCure Pharmaceuticals and Dr. Abhishek Thakur for helping us all this while. Thank you, Dr. Rufin Montero, and thank you, Dr. Amol Tilve from IMA State for allowing us the state level conference. Thank you everyone for attending. That was a whooping 176 attendance. Thank you everyone. Good day, sir.
Okay, thanks a lot. Thanks a lot.
Thank you everyone. Thank you, IMA Goa. Thank you, Amol sir. And thank you all the delegates who actually were present throughout. This attendance was really amazing. And after 2 years also, people are not, people are actually still coming for the webinars. That's really appreciable. And thanks, Dr. Mol, for your wonderful presentation, sir. Thank you. We'll be more than happy to be partners in upcoming events also. Thank you, everyone. Have a good night.
Oh, good night. Yes, bye.